Good afternoon, or good morning, depending on where you are, and thank you for joining us for our webinar today. I'm Kimberly Westrich, the Vice President of Health Services Research with the National Pharmaceutical Council. The research that we are sharing with you today is designed to build on a project that we conducted with Discern Health in 2014. That particular project looked very broadly at accountable care quality measures for high-cost specialty care and innovative treatments. The research we're sharing today is specifically focusing on cancer, assessing the adequacy of oncology-specific accountable care measure sets, and identifying where the priority measure gaps are. As part of this research, we convened a multi-stakeholder roundtable to consider the work and identify strategic solutions to the measure gaps, and more importantly, short-term action items that could be taken to improve oncology measurement under accountable care. We'd like to thank the roundtable participants for their time and thoughtful engagement, and their names and affiliations are listed on these two slides. We very much appreciate their input throughout the project. We'd also like to thank the Oncology Quality Measurement advisors from NPC's membership who provided guidance throughout the research. I'd like to note for the record that no individual member of NPC had a disproportionate influence on the research process. So I'll give a brief introduction to our four speakers in the order that they will speak today. First up will be Dr. Tom Valuck, who will share the research project findings and recommendations. Dr. Valuck is currently a partner with Discern Health, and his work there includes, among many other things, exploring next-generation measurement and accountability models for healthcare delivery systems. Previously, Dr. Valuck served as the Senior Vice President for Strategic Partnerships at the National Quality Foundation and as a Senior Advisor and Medical Officer at CMS, where he advised senior leadership regarding Medicare payment and quality of care, and particularly focused on value-based purchasing. Next, we'll have three reactors responding to the research. Dr. Robert Miller will share the provider's perspective. Dr. Miller is currently the Vice President of Quality and Guidelines for the American Society of Clinical Oncology, more commonly known as ASCO. He's responsible for ASCO's quality portfolio, and the quality portfolio includes clinical practice guidelines, performance measurement, quality informatics, and COPI, the Quality Oncology Practice Initiative. Dr. Miller is also Medical Director of CancerLinQ, which is ASCO's revolutionary big data technology platform to support a rapid learning system for oncology. Dr. Miller is a highly seasoned oncologist and informaticist, and he has over 24 years of combined experience in community oncology, academic medicine, and administration. Next up will be Dr. Alan Balch, who will share the patient perspective with us. Dr. Balch is the Chief Executive Officer of the National Patient Advocate Foundation. Over the years, he has led numerous federal advocacy efforts, both legislative and regulatory, on a wide range of issues. For example, he helped organize and lead a coalition that fought for improvements in the regulatory process for the review of cancer drugs at the FDA. He also contributed key concepts and statutory language to important provisions in the Affordable Care Act. Prior to his role with the National Patient Advocate Foundation, he was the Vice President of the Preventive Health Partnership, and the Preventive Health Partnership is a health promotion collaboration between the American Cancer Society, the American Diabetes Association, and the American Heart Association. And last, but certainly not least, Dr. McClellan will share the payer and policy perspective. Dr. McClellan is currently the director of the Duke-Margolis Center for Health Policy, as well as the Robert J. Margolis Professor of Business, Medicine, and Policy at Duke University. His work has, of course, addressed a very wide range of strategies and policy reforms to improve health care, including payment reform, development of methods and use of real-world evidence, and approaches for more effective drug and device innovation. Dr. McClellan has a truly unique background. He is both a doctor and an economist who has served as former administrator of CMS and former commissioner of the FDA. We're pleased to have all of you with us today. And with that, I'd like to turn it over to Dr. Tom Balch.
Thank you, Kimberly. Hello, everyone, and thank you all for participating in the webinar today. I'm very excited to present the findings and the recommendations that Discern Health has worked with NPC and the roundtable that Kimberly described to develop. In addition to thanking NPC for their sponsorship of this important work, I want to thank Dr. McClellan and Dr. Miller, who were the co-chairs for our roundtable and who are going to be presenting their perspectives today, and also all the roundtable participants, including Dr. Balch, who's also going to be presenting today. So the project scope was to examine the quality measure landscape for 10 high-impact cancer types, and I'm going to be telling you how those were selected and what those were. And then to identify gaps in the available measures and measures in use for accountable care models. Again, I'm going to be describing which models and what we found in terms of available measures and gaps. In addition to looking at measures specific to the 10 high-impact cancer types, we also, under the project scope, work to identify cross-cutting measurement opportunities that assess issues for multiple types of cancer. And then beyond the specific measures, we wanted to look to strategies that might be enacted at the policy level along with the near-term action steps for improving oncology measurement. We also want to describe a few limitations to our project so that we can put it in the appropriate context. So first of all, we're focused on quality measurement today, but measurement is only one of the many tools that can be used to promote improvement. We don't want to forget data analytics or practice improvement projects along with measurement. They all go together. And we also don't want to forget that lack of quality measurement does not imply that providers will not deliver quality of care. This is as much about rewarding the kind of care we want to see and understanding where we have opportunities for improvement as it is accountability. In addition, even though we focused on accountable care, it doesn't mean that we're only looking at accountable care organizations. Very important distinction. We're not just looking at ACOs and ACO measure sets, although they're part of this, but accountable care extends more broadly to bundled approaches, payment for performance approaches on top of fee-for-service, for example. And then our output, as you'll see in our findings and recommendations, was really at the measure concept level, not so much at the measure specification level. We weren't intending to say this specific measure should be used or this specific measure set, but to think more broadly about measure concepts, but more than just measure domains. And you'll see what I mean as I proceed through the presentation. We also weren't describing the problems that we see with accountable care in terms of inappropriate care that might result from cost incentives without corresponding measures, even though that's an assumption here that incentives can create unintended consequences, that developing the evidence behind that was not within the scope of this project. And last, but also very importantly, it was not our goal to suggest that all processes that are described by the evidence-based practice guidelines have to be measured. What we're trying to do is get to the right measures, the best measures, the fewest measures needed in order to accomplish the important goals of measurement. So with that background on the scope of our project, and also clarifications and limitations, I want to describe our methods briefly. So one of the things I said that I would describe would be how we selected the 10 conditions and what those 10 conditions are. As you might imagine, we looked at conditions that were high incidence and prevalence, also high in terms of being causes of mortality, and high costs. So the things that would create a burden to society and to individuals. We also wanted to look at a range of kinds of cancer, whether it was different types of treatment, drug therapy, radiation therapy, surgery, or short versus long-term episode of care, and cancers that affect both genders, for example. So we wanted that whole range. And then we also wanted to look at how socioeconomic, racial, or access-oriented challenges might play across these different conditions that were selected. So as you'll see on the right hand of the slide, we selected conditions that you would expect to see on any list of high-priority cancer conditions, like breast cancer, colon cancer, lung cancer, prostate cancer. But we also wanted to look not only at solid tumor, but also blood-related cancers like chronic myelogenous leukemia and non-Hodgkin lymphoma. And then we wanted to again, get that variety and diversity, so we looked at kidney cancer, malignant melanoma, ovarian cancer, and pancreatic cancer to round out the list. And for those specific conditions, we applied this process, this approach to our project. Started by looking at the evidence-based guidelines, primarily NCCN, but also guidelines from ASCO and ASH and other organizations, and then compared those guidelines to the measures that are actually being assessed in accountable care programs. And where we saw gaps, we noted those, and then looked at whether there are available measures to fill those gaps in the measure sets for accountable care programs. And then ultimately, where we didn't find measures in use in programs or measures that could fill gaps in programs, we were left to identify a gap in measurement, typically a measure development issue. So those are the first 5 steps that you see there. And then we looked across all the conditions to get that bird's eye view for the cross-cutting policy recommendations. In terms of accountable care models and their measure sets that we used to identify measures in use and ultimately gaps in measures for those sets or de novo measure gaps that need development, we looked at a couple of types of models that were not cancer specific, including ACO models, specifically the Medicare MSSP, Pioneer, and Next Generation models, as well as the quality payment program for physician Medicare physician payment, including the measures for MIPS, the Merit-Based Payment Incentive Program. But we also looked at a few oncology-specific models. The Oncology Care Model that's been put forward by the Center for Medicare and Medicaid Innovation, as well as the measures that are being used to assess care within the PPS-exempt cancer hospitals for their Medicare patients. And then we looked at one private sector model, the United Healthcare Chemotherapy Episode Payment Model. So as Kimberly described, we had a multi-stakeholder roundtable review Discern's findings and react to some straw person recommendations that we put forward. And we were very pleased at not only the caliber of the participants, but also their engagement and the input that we received from them. They provided the recommendations, input on the recommendations and strategies that you're going to see me present. So moving on to our findings. So first, to look at the measures that are present in the accountable care measure sets that I referred to. The QPP MIPS, the CMS ACO set, as well as the Oncology Care Model, the PPS-exempt cancer hospital measure set, and the United Healthcare Quality Initiative. So first, let me differentiate between the first 10 rows under cancer type and the last row, which is cross-cutting. So the first 10 rows are condition-specific demonstrations of the measures that were part of those particular accountable care measure sets. Condition-specific, in this case, refers to any quality measure that includes patients with a specific cancer type, such as breast cancer or any of the others on that list, actually in the denominator. So the denominator needs to include a reference to a specific cancer type, and then we call that condition-specific measurement for the purposes of this project. But we also wanted to consider cross-cutting measurement, which refers to any relevant measure that includes general populations of cancer patients in the denominator. So if the denominator says patients with cancer as opposed to breast cancer patients, then that would be a cross-cutting measure. So as you see on this table, then, for the MIPS measure set, we identified 26 condition-specific measures and 9 cross-cutting measures. So of the 271 measures, about 30 of them are related to care for cancer patients, either directly to a specific condition or more broadly. For the ACO programs, you see a much narrower reflection at the population level, a couple of screening measures, one for breast cancer, one for colon cancer. For the oncology care model and the PPS exempt cancer hospital set, you see measures there for breast, colon, and prostate cancers. And these are actually the most common cancer conditions that were covered generally in these accountable care measure sets. And then there are also cross-cutting measures for those programs. And then the United Healthcare measure set included breast, colon, and lung cancer, as well as cross-cutting. Some examples of cross-cutting measures that we see that populated that bottom row there included radiation dosing safety, planning for and quantifying pain, and screening for clinical depression and developing follow-up plans. So those are examples of cross-cutting measures. Condition-specific measures might include things that you would expect around screening, timeliness of therapy, chemotherapy, for example, use of targeted or adjuvant hormonal therapy, specifically for the more common of the measures that we found for conditions like breast, colon, and prostate. On the next slide, we have some of the cancer-specific measures and measure opportunities for the 10 types of cancer that were selected. So you can see in terms of the identified opportunities, that column, that's where we looked at the clinical guidelines and we assessed where there might be opportunities for measurement, such as for diagnostic testing and monitoring, initiation of appropriate therapies for cancer patients, initiation of radiation or as opposed to drug therapy, or surgical interventions as opposed to drug or radiation therapy at certain stages of cancer, and clinical or functional outcomes such as survival or unexpected loss of a bodily function. So for those opportunities that we identified by reviewing the guidelines, we also found available measures. As you see there are a number of oncology measures, particularly for breast, colon, lung, prostate cancers. But we also noted some gaps, very few measures, for example, for CML or for kidney cancer. And then in the final column, you see most of the cancer types that we reviewed had many remaining gaps when you compared the available measures to the opportunities that were identified. And in fact, there were, as I said, few or no measures for CML and kidney cancer, so almost all of the identified opportunities were actually gaps. Now, you might note that these numbers don't sum across the available measures and gaps to equal the identified opportunities, and that's because some of the measures would address multiple opportunities, and so it's not a one-to-one correlation. So we also looked at cross-cutting measurement opportunities. So in addition to the condition-specific gaps that I just mentioned, we wanted to think beyond that to how some broader measures might address some of those gaps, as well as create efficiency in measurement. So you see some of the types of measures that are presented here are patient-reported outcomes, and specific examples there include change in health status during treatment as reported by patients, continuity of care planning, provider communication, and the quality of that communication, and definition of treatment goals and assessment of whether they're met. We also identified some clinical outcome measures as cross-cutting opportunities. Survival, for example, measurement of residual disease, cancer recurrence, appropriate use of services at the end of life. And the roundtable noted the importance of risk adjustment for these clinical outcome measures. In addition, we saw some cross-cutting opportunities for process measures like appropriate staging, the collection of information about tumor status and genetic information, appropriate chemotherapy dosing or change in dosing, adherence, issues around protecting fertility, and appropriate processes for that. And then safety measures, very important cross-cutting measures, particularly for never event type adverse events. And then lastly, you'll see there are some structural measures like HIT, adherence to guidelines. I'm going to talk a little bit more about that in our recommendations, and adherence to palliative care standards are just examples of some of the high priority measure opportunities that are cross-cutting in addition to the ones that were found for specific conditions. So the last slide on findings is about the implications, and that will lead us into our recommendations. So we found that the accountable care measure sets, as you might expect, typically focus on high prevalence cancer types and omit measures for assessing other important cancers. And when you take into consideration that the cost of care is being measured across all of the conditions, we really need to think about where we've omitted the corresponding quality of care measures for those conditions. That numerous process measure gaps remain, areas like mutational and biomarker testing, utilization of services like imaging, medication adherence, for example, but also we need to look to cross-cutting measures for filling some of the gaps. We have some good cross-cutting measures for pain and hospital and ER visits and depression screening, radiation safety, but there are also gaps in cross-cutting measures, for example, for patient-reported outcomes and perhaps for getting staging, survival, and disease recurrence right. So in terms of our recommendations, we'll now come up from the very cancer-specific findings to some generalizations that actually are very similar to what we need to do together to get to better measurement in general, but specifically to improving measurement for oncology care. So the first is, you won't be surprised, the roundtable very much supported the idea of developing cross-cutting measures and getting those into measure sets. Now, there are some organizations out there that have been working on measure sets. For example, CMS and AHIP and other stakeholders have been part of this core quality measure collaborative and have a really good starting place for the core set of measures for cancer. But the roundtable identified some opportunities to add cross-cutting measures to that particular set. And then suggested that other developers and those selecting and adopting measures should also look to cross-cutting measures. Second, issues in model design and measure development. A lot of good ideas that we might have about measurement are stymied by the methodologic issues and also the lack of data, which I'm going to be describing as a final recommendation. But in terms of the methodological issues, some of the examples are small numbers for individual physicians or even groups. We find in cancer care where we have some rare diseases. Risk adjustment continues to be a vexing problem, particularly for outcomes. And then benchmarking and attribution, getting the fairness right for these programs and assigning the accountability correctly. So the idea is that groups that have the expertise and also the gravitas in this area ought to be looking at some of these methodologic issues, particularly government organizations, agencies that have funding ought to be investing in this direction. The third recommendation is to enhance our understanding of the issues related to development and use of patient-reported outcomes. This is an area of measurement that's getting a lot of attention across not only oncology care, but much more broadly, because it's a way to not only assess what's important to patients in terms of their clinical outcomes, but also in terms of their preferences. And I know that Alan Balch is going to say more about the patient's role in measurement. And so attention, investment there, again, from both the public and private sectors is welcome and necessary. I would note that the National Quality Forum's incubator is doing a lot of work in patient-reported outcomes, and that's a very positive step forward. The next recommendation is about improving and standardizing clinical pathways. So a lot of effort has gone into the clinical guidelines, and we've got some very sophisticated clinical guidelines for oncology from NCCN and other organizations. And we know that we can't measure every single step in those guidelines. It's not feasible or desirable. So using those guidelines as pathways for care and assessing compliance with the guidelines is something that could be very, very positive and useful in oncology care. And I think some of the reactors to my presentation are going to be talking a bit about guidelines and pathways. But in order to use them, we need to recognize that they are limited in some ways, that no single pathway is going to apply to every patient with a certain kind of cancer. We also need some sort of standardization or review for pathways. And in fact, the roundtable went so far as to recommend an independent entity to review and standardize clinical pathways. I have two more recommendations here. One is to utilize a layered measurement strategy. And what I mean when I say layered measurement, it's a way to get alignment across various levels of analysis so that the measures make sense as a coherent whole across those levels of analysis. And that allows for either drill down to more specific information that measures might tell us, or aggregation, roll up more to the population level. And so both the NQF's Measure Application Partnership as well as the National Academy of Medicine's Vital Sign Report call for a variation on a layered measurement strategy. If anybody has questions about that, feel free to contact me after the presentation, because I've been a big proponent about a layered measurement strategy and would be happy to talk further with you about how that could work for various challenges that you might have in alignment. Our last recommendation from the roundtable is to accelerate interoperability and functionality of data platforms. And these are things that we've been talking about from the HIT perspective for a long time. But really, when it comes right down to it, we can only measure what we have the data for. If we don't have the data, we can't calculate measures. So we've got to figure out how to get better patient-reported information, the kinds of information over time that we need to assess clinical outcomes, and get more efficient so that we don't continue to burden the providers with data collection. One way to do this that the roundtable was very much in support of was identifying a core set of essential data elements and making sure that those get into the certification requirements for EHRs and other tools that could be useful in generating the kind of data we need for better measurement while not burdening the clinicians. So that's our overview of the findings and recommendations from the project. We're very much looking forward to reaction from Dr. Miller, Dr. Balch, and Dr. McClellan. And we're going to start with the comments of Dr. Miller. So Bob, I'll hand it over to you.
Great. Thank you so much, Tom, and thanks to Discern and to NPC for really some terrific work on this process over the past almost year now. It was a thrill to be involved, and I think we've really moved the needle in some of these recommendations. So I'm really honored to be here today and speak to all of you to share both some of my personal perspective as a practicing clinician, at least previously in life, but also some of the work that ASCO has been doing in the quality space, focusing specifically on quality measurement for cancer. So ASCO is the world's leading organization representing physicians and other clinicians who care for patients with cancer. We're about 42,000 members now. And ASCO's three pillars of its mission are at the top of this slide here, and that's really working to conquer cancer through promotion of research, through education, and probably most importantly in the last 5 or so years is the promotion of the highest quality patient care. And ASCO does this through a number of the programs that I have on the slide here. The one that may be the most familiar to many of you is the Quality Oncology Practice Initiative, or COPI, which is now in its 11th year of existence, which is sort of a homegrown grassroots quality assessment and registry for ambulatory care in largely in medical oncology, but a number of these other programs. And we've been working intensively in this area to really bring this to our membership and to the patients that they care for with this primary goal of promotion of quality patient care. And to talk specifically about some of the programs, ASCO has been involved in developing clinical practice guidelines. ASCO has published now, I believe, almost 70 clinical practice guidelines or other guideline products like provisional clinical opinions. And these are both disease-oriented for specific cancer types or in some cases modality-oriented. And these guidelines, which are highly evidence-based and very rigorous, address really a wide range of cancer treatment and diagnoses issues that practicing oncologists face. And it's from the ASCO guidelines that many of the clinical quality measures that ASCO has authored or otherwise supported over the last 5 to 10 years have been derived. As I mentioned, the COPI, the Quality Oncology Practice Initiative, is an oncologist-led quality assessment program that's very grassroots-based. And most importantly, I think it's important to emphasize that this is really designed to create a culture in oncologists. And this is long before there was something known as macro or any of the current external compliance programs, as a response in part to the Institute of Medicine report about cancer care quality and to err is human. ASCO leaders developed this program, and really it's been very well received by our membership. Something in the range of about 1 in 3 to 1 in 2 medical oncologists in the U.S. have participated in COPI at some time during its life cycle. And the program now has about 200 clinical quality measures, largely process measures, and we'll talk a little about some of the limitations there. As an offshoot of COPI, we have developed an on-site quality training program, and this is really a tool for practice-led teams to come to ASCO headquarters or to other places and participate in these short courses to develop quality improvement projects in their local environments. Again, this is something that has been well received by our membership. Quite a few members look to improve the quality of care that they deliver, but they don't know how. And this type of sort of introduction to the whole idea of quality improvement, again, very much at the grassroots level, has been very successful in opening this up to practices and to centers that have prioritized this. And finally, the CancerLinQ program is our latest and probably our most ambitious initiative. CancerLinQ is a big data health technology platform that is working to improve cancer care quality by first aggregating data from oncology electronic health records in a single de-identified database. But as part of that and embedded within the platform, the electronic clinical quality measures, performance indicators that are based on ASCO COPI measures, are fed back to the practices, so clinicians can see real time how they're performing on some of these metrics, and also the big data aspects create new opportunities for insights and data exploration to develop new hypotheses for future care. And all of this fits together. There's this quality loop that we've built internally. Again, this is probably familiar to most of you, but the evidence forms the basis for the creation of the guidelines. The clinical quality measures are built from the guidelines. These are brought into both the COPI program, which is a manual program, and the CancerLinQ program, which is automated. But the important part is the backward loop, the left-facing arrow there, and that's the idea that the actual outcomes that are seen within the CancerLinQ system data to inform the development of the guidelines in the first place. And what we have been finding in some cases is that what really happens and how the guidelines are used is sometimes vastly different than what we expect being written in the somewhat sterile environment of academia. So it feeds back to inform the guideline development. It's impossible to talk about quality measurement in oncology without reflecting on some of the realities of the rapidly changing and if you will, just incredibly fundamental changes in the requirements for quality. I think it's probably familiar to everyone on this call that there's been this sea change of programs and the requirements that all clinicians are required to adhere to as part of federal reporting requirements. And you know, the top row there, the older programs like Meaningful Use and PQRS have now been merged in many ways into the programs that came out of the MACRA legislation from a couple years ago, specifically the Quality Payment Program. And I think that the reality is that oncologists are deeply they're facing this issue and they're deeply involved. It's right, but to some extent, the quality measurement that oncologists have to put at the forefront, because it's going to be intimately tied to their reimbursement and their survivability in the practice setting, is going to be the measurement that CMS dictates that's going to be required to meet as part of the quality payment program. And as you may be familiar, there are really two pathways that are part of the quality payment program. Most of the focus, as Tom mentioned now, is on the merit-based incentive payment system, which is more familiar because it's based on some of the existing clinical quality measures. But I think that we're certainly going to see a migration more and more toward the alternative payment models, the APMs. Right now, in oncology, we are because we have an early form of this APM in the oncology care model, the OCM, which about 200 oncology practices around the U.S. participating in right now, and I think it's going to give us teach us some important lessons about how to get this part right. But the reality is that in 2017 and 2018, oncologists will have to participate in MIPS for all the patients that are part of federal reporting programs. And within the MIPS program, currently configured, about 60% of the total MIPS score comes from meeting the quality reporting requirements. And I won't go through this in detail. I think this is familiar to many people, but I think it's important to recognize that this, again, is a next step. It's a much higher bar than physicians have ever had to jump over before, because while it's only 6 measures for next year, the clinicians must report on at least 50% of the eligible patients for each measure and have a 20-case minimum. So this is something that almost requires electronic tools for data abstraction and reporting, because of the burden of seeing these quality measures applied to large populations of patients with common malignancies like breast cancer and prostate cancer. And the other important factor of the MIPS program is that this applies to all payers. It's not just to Medicare patients. There must be at least one Medicare beneficiary for each measure, but it applies to the entire population. And I won't spend any more time on this, but I think it's important to understand that intensively focusing on this in 2017, because the clock is running right now, and we have to do some reporting in 2017 before it really kicks into high gear in 2018, and we really have to get this right. And this is an environment where, even though this may be fully congruent with the idea of the importance of quality reporting, doing this in the systematized fashion that this type of external reporting is going to require is really sort of new territory for a lot of oncologists. And so to react more specifically to some of the things that Tom presented, as I said earlier, I think the recommendations that came from the roundtable and that you'll see in the white paper are really terrific, and I think there's a lot of practical advice that oncologists, I think, can rally around. But just to make a couple specific comments, one is there was a lot of discussion about the importance of cross-cutting measures. And I think this is something that we all... I think it's important not to overlook the challenges of moving from disease-specific process to the more cross-cutting measurement tools. Process measures that focus on that ask questions like, for patients with early-stage breast cancer, did they receive appropriate hormonal therapy when their cancer was estrogen sensitive, and so forth. This is sort of the bread and butter of oncology measurement. It's been so for the past 10 years now. And one of the reasons I believe that to be the case is this whole attribution that Tom talked about, the idea that to which clinician are you going to assign the responsibility for this measure, as cancer care is becoming more multidisciplinary and more clinician specialties are being involved in the care of the patient. The attribution are very tricky. And that also speaks to the whole challenge of risk adjustment that Tom spoke to. We have patients that are increasingly less healthy, that are being seen in our clinics, that are becoming candidates for more and more adjuvant therapies and potentially effective therapies like immunotherapy. But these are not typically the patients that are seen in clinical trials, healthiest cancer patients and the ones for whom the guidelines are written. But they have comorbidities and they have other times socioeconomic challenges. But we have to figure out a smart way to be able to take into account some of those effect outcomes. And I would submit that this is something that we haven't really gotten right yet. I think that the whole risk adjustment area is one that needs much further research and really needs to be implemented very thoughtfully before we start reimbursing on their performance with risk adjustment is not taken into account. And then we talked about pathways. Clinical pathways have become very prevalent in oncology over the last few years, and I think most oncologists would recognize that these are good things in the sense that they standardize care in many ways in a good way. They provide evidence, a basis for comparing different forms of care, and I think they're comforting to many patients to know that they're delivered based on some type of a guideline or a pathway that has strong evidence behind it. But nonetheless, there are many challenges with pathways. There's been a of pathways. There's been many pathways from many different insurers and plans, and the requirements are sometimes baffling to right. And then there's the whole challenge of allowing reasonable deviations from a pathway. A clinical pathway couldn't possibly be this patient because of the issues of age and comorbidities. And the measures that relate to clinical pathway adherence most certainly have to allow for reasonable deviations based on different clinical characteristics. And in many ways, most importantly, I think that there is great value to incorporating the patient voice, the importance of patient-reported outcomes and not exclusively clinician-assessed outcomes cannot be overemphasized. And I know the next speaker, Dr. Balch, will speak to this, but I think that the time has come now for the research out the best tools, the best strategies for implementing the patient-reported outcomes into measurement, and I think there are opportunities to do this, and I would submit that in this era of change with macro and MIPS, this is probably the right time to introduce some of those concepts, and I think this because they recognize all too well that this is the right thing to do, and finally, I think we have the infrastructure in place, starting to be in place to get this right. So I'll stop there, and we'll move on to the next speaker. I would like to introduce Alan Balch. Alan is the CEO of the Patient Advocate Foundation, and I know he's going to have some great perspectives on the patient's perspective. Thank you.
Thank you so much. And please ping me online if you're not able. So appreciate those comments. I'm going to respond from the perspective of patients. Just a little bit of background on who we are at Patient Advocate Foundation. For those of you who don't know, we are really at the forefront of help and assistance around access and affordability. So we primarily serve low-income patients. Average income level is about $23,000 household annually with a household size of 2. So most of the patients are within or below the 200% federal poverty. Most of them have cancer. 70% are cancer. They come from across the country, and most of them are having some sort of have run into some barrier, whether it's transportation, whether it's they can't afford their rent or their utilities, or they can't afford their treatment, or they have a hospital bill or prescription they can't afford to cover. So it's a wide variety of different issues that patients arrive at our doorsteps with, and we do that through a variety of means, one of which is what we call case management. And those case managers will be assigned to them, and we'll spend any amount of time necessary to try to address their. I just have a few bullet points here for you, but I'm mostly going to speak more broadly. We certainly applaud the shift from volume to value and what that means in terms of trying to shift the incentives within the healthcare system more broadly. Obviously, measurement and the measure set are going to become the coin of the realm, if you will, around as a basis for how payments and incentives are delivered. I won't reiterate what's already been addressed around macro. I think what it really speaks to, though, from a patient perspective, is just as we have to how we do clinical trials and research and discovery. If we're truly transforming care, we also have to how we measure care. And I think from a measurement perspective, we're using what I would consider to be largely outdated, and not that it's bad technology, and in some cases it's still applicable. But we're using process as has already been mentioned. We're sort of stuck in this rut with process measures, et cetera, and a lot of talk about moving to outcomes-based measures, but and that's not a criticism of any one group. There's lots of people trying to get there, and we're trying to do our part as well. But I think it all boils down to, at this point, really what is it that matters to patients? How do you translate that into an outcome measurement that can be used as a reasonable basis for payment? And I think that's sort of the rub here is everybody would like to envision this world where there is outcomes-based, it could even be patient, but it has to meet of robustness and validity that and can be for payment. And I don't have the answer to that question. I'll say that right up front, but I do have some insights into perhaps how we might need to think differently about measurement, sort of where measurement process. So I think just thinking of measurement as an isolated event or as a silo, if you will, just like we're trying to coordinate care in these accountable care models, I think, integrating and coordinating across cities and tools, I think is going to be helpful to explain what I mean by that. I think it starts with shared decision making, right, and having some process by which that occurs in a meeting, and then that shared decision making process has to feed into a goal concordant care plan. And I know, for example, the oncology care model envisions some level of shared decision making and a care plan. There's the 13-point IOM care plan as a requirement, so it doesn't specify that those things have to be linked together, but it does set up, a set of requirements that really lead to the need for shared decision-making in a care plan, but those two things have to flow together and have to be connected, and that's where the measurement comes in. If you combine those three things together in an integrated way where the shared decision-making leads into a goal concordant care plan, and then that care plan at least has some aspects of it that are related to the measurement set that's used to assess that patient's care, then I think you've really connected those three in a way that is coordinated. You wouldn't have other types of measure sets that may be nature that may not be patient reported, but there should be some of the measure set that is really to that patient's care plan and resonates with them, and they contribute to that data collection, and they also have the ability to use those data to track their own progress and to give feedback to themselves and to their providers about very specific outcomes that are important to them, whether it be side effects, whether it be clinical, treatment benefits, whether it could be other issues around financial distress, transportation issues, etc. So that, and then if you can then aggregate those data into a more global set that then could be form that sort of real-world evidence, rapid learning environment, I think you've now created a feedback loop that has a macro-level purpose that could help inform other decision makers, both at the provider level and especially the patient level, so they can see what the experience of patients who have gone before them as it relates to important outcomes that they are considering as part of their care. So coming back to the deck here and the bullet points in front of you, I think we really need to think about, and this is a theme across as we're transforming healthcare. How are we doing it in a way that matters to patients? And that especially, it's very true for measurement because it's going to become such an important element of the incentive system for care and delivery. So are the measure sets we're using meaningful to patients? And the point was made earlier about cross-sectional versus patient-specific. I think there needs to be both. I think if the measure sets are too standardized and too cross-sectional, then you really lose that personal, really lose the ability for the measure sets to have relevance to the individual patient. And I think the challenge is here is we don't want to fall into the same trap that we've had for many years across different healthcare settings of presuming we know what's important to the patient and limiting that treatment experience to sort of father knows best or we've decided for you what the most important measures are. There are some that are somewhat universal, but what in cancer in particular, a side effect, an acceptable side effect for one person may be an unacceptable side effect for another, and obviously different treatment options have different side effect profiles. So this idea that we can kind of come up with what's the universal outcome measure for every patient and apply that universally, that may be true to some extent, but I think it's going to be more having a range of options that could be applied to a set of circumstances and letting the provider and almost having a shared decision-making process, if you will, for what is of the measure set, what subset of that really is specific to this particular patient and what are the most relevant outcome measures for that patient. So it gets you into areas of, there's obviously some important domains of the process for patients. So I'm not saying that we shouldn't have process measures. I think the process of communication and shared decision-making and goal concordant care plan, those are all important processes for patients that lend themselves to process-based measures. But then you get into outcomes-based opportunities as it relates to patients understanding functional status, different side effects, types of benefits, treatment benefits. But again, I think as much as if we can figure out how to carve advantage of patient preferences and aligns the measure set to some degree with the care plan of that individual patient and their priorities, I think then you're investing the patient themselves in the inherent value and the intrinsic value of collecting those data and having it be relevant to their experience. And I think there should be some, that then creates some accountability for the providers around the selection of patient-reported outcomes and, the ability to connect the treatment they're trying to provide to the patient's goals and preferences, and then ultimately some of the measures that are being used to assess that and pay for that care. And then I do think there needs to be some, the last bullet point here is, some other key outcome measures to keep in mind in addition to the ones we typically think about with regards to side effects and benefits and the patient satisfaction suite that I call them the hospitality measures, which are important to patients. I'm not trying to minimize those. How polite, how respected, how are you treated by the care team and by the receptionist, for example, access to 24/7 scheduling, free parking, those things, those sort of that hospitality set of satisfaction measures are important to patients. And certainly those are things that patients can report on from their perspective, but I think patients can also tell you quite a bit about their side effects and how those are affecting them. Obviously, the benefits of their treatment, different patients have different ways of sort of evaluating whether their treatment is working. But then you also have things around access and socioeconomic factors and financial toxicity, things that we don't that would sort of fall outside of those, benefit, side effect, and hospitality type or satisfaction type of measures that are also important to patients, and tracking those and having patient-reported outcomes around those measures are very important because, A, those are oftentimes, as I alluded to at the beginning of my comments, a lot of those things are the stumbling blocks for patients as they're moving through their care. So their inability to afford their housing, their rent, their groceries, those are things that impact their day-to-day life and get in the way of their ability to maintain adherence to care, to successfully navigate their care plan. So if we don't include those types of issues in the measure set and track those, then I think you're losing an important opportunity. Not that the practitioner or the provider is responsible necessarily for those things, but I think having information about those and the impact that they have on care also helps inform and even trigger important social support services that will help the patient endure those bumps in the road, the things in life that get in the way of your care, that especially for low-income patients, that really have a dramatic impact on care. So I'll leave you with this statistic just as an example, and this is only from our own patient population, but when we query our patients and ask them about their financial experience, for example, and this is only representative of our patient population, which is low income, most of them, as you would expect, experience a significant amount of financial distress. And one of the top consequences of that is actually the inability to afford groceries. So I'll leave you with that just to give you a sense of how, the level of complexity for some of these patients that impact their care that we often don't think about in terms of, when we're talking about oncology measurement. And with that, I'll quickly introduce our next speaker, which is Dr. Mark McClellan from the Duke-Margolis Center for Health Policy. Take it away, Mark.
Thanks very much, Alan. It's a real privilege to be on this webinar with you and Kim and Tom and Bob on this topic that's so important to the health and quality of care for Americans. And just want to start this discussion of some of the payer and policymaker takeaways from this effort with picking up right where Alan left off, just a reminder that the goal of measurement is not measurement for its own sake, but to enable better care throughout the care pathway of individual patients. And in the case of cancer, that's all the way from prevention and risk modification through screening and diagnosis and care planning with shared decision-making, initial treatment, symptom management, longer-term surveillance, well-coordinated care, reflecting patient preferences for advanced illness. At all these steps, measures can help, not just for payment, important as that is, and I'll come back to that, but for quality improvement efforts that healthcare providers are seeking to undertake, for more effective decisions by patients with their healthcare providers, and for our policies on payment and in other areas, and for helping to figure out what is really working to improve outcomes and avoid unnecessary costs in our healthcare system. And I think one of the things that I take away from this report, aside from just the importance of laying out where we are in measurement related to oncology care, is that there are a lot of gaps. Despite the wide recognition of the importance of measurement for oncology care, there are significant gaps in data. There are significant gaps in methodology, and that might leave you feeling with a sense of just how daunting this effort can seem. But what I would emphasize alongside of that is that the real focus on the report is how to move forward from here. There are a lot of challenges, and you've heard about them in Tom's summary and in some of the comments from Bob and Alan as well. But this is intended to be a roadmap that draws on the existing resources, on what we know now, on a number of initiatives that are underway now to improve measurement, and get to the point where providers and patients can use it more effectively to improve care, where policymakers can tie healthcare payment and other policies in a way that does a better job of promoting that better care. It's not just about measurement for its own sake. And among the takeaways, the ones that listed on this slide, include the importance of paying attention to a range of dimensions that really matter. Meaningful outcomes are important and can be hard to measure for all the reasons that have been discussed. Also, measures of appropriateness of care, care pathways, and we've talked about that, and also resource use with concerns, as Alan mentioned, about financial toxicity and whether the drugs and other treatments involved in cancer care are really worth it. That's an important set of, or this more important set of dimensions as well. And in all of these areas, I think there are opportunities for moving forward that the report has identified. And this is certainly important because of the prevalence of avoidable complications, of opportunities to involve patients more effectively in decision-making, and helping them get the treatments that they would prefer with more confidence as we move into an even more personalized system of cancer care. The steps to do these things in care often don't get as much support as they should. Support in the form of good evidence-based practices based on not just clinical studies but real-world evidence, and support in terms of resources. So continuing to develop the measure sets that balance these different dimensions will help us improve in doing that. The report highlighted the notion of core measures, measures that could help inform both treatment selection and other aspects of care. The report emphasized opportunities to improve and standardize existing pathways. That's something that Bob mentioned as well. If there were measures that could cut across different payers, different contexts, and again focus on patients, that would help. And while pathway adherence measures have their limitations, they certainly don't apply to all patients, and they need to evolve with the knowledge about what works in particular patients, pathway adherence is a potential cross-cutting type of measure, one that if it could be standardized across more payers and more settings, could be more useful in helping to promote better care. I want to also emphasize the importance of outcome measures. This is an area when we should be moving into paying more attention to individual patient preferences, and when the technical capabilities for doing that, for collecting data more easily and reliably from patients are getting better and better. So the report appropriately emphasizes the pathways for improving the use of patient-reported measures and some of the challenges around data systems for doing that. So there's a good set of paths forward here on core measures, on a balanced approach to performance measurement to support a wide range of initiatives. But we do have some challenges in getting there, and I want to turn to the next slide, which describes some of the resources that are included in the report that can help us get there. One of those is around models that can use and create more support for these performance measures. And here the slide emphasizes payments. So I think I'll spend just a couple of minutes talking about payment-related issues, since that is something foremost in the mind of many clinicians now because of the implementation of Medicare's payment reform systems and the general movement in the direction of value rather than volume-based payment. Would make a distinction between those two avenues that Bob mentioned earlier. One set in the MIPS program that's still fee-for-service-based payment systems with some measures of quality that are included on top of those payments as adjusters, and those certainly are measures that clinicians who don't have better alternatives are paying attention to now with the implementation of MACRA. But there's another pathway, the alternative payment models. Tom mentioned this at the beginning. These models have in common a shift towards more of a patient focus and away from a focus on paying for specific services. So measures like the oncology care model in Medicare and measures like some of the oncology payment reform initiatives in private plans have more of the payments tied to something like a risk-adjusted per member per month payment to medical practices that goes along with some accountability, ideally in a balanced way around outcomes and processes of care and capabilities and costs, some expectations for improvements in these dimensions. And that's leading to a lot more interest in developing measures, not just for the sake of reporting and payment adjustment, but for sake of as providers have more flexibility and resources to deliver care and maybe more opportunities to invest in better systems, measures that can serve multiple purposes, that can help with quality improvement, that can help with engaging patients, and that can help with making sure that the reporting requirements are not excessively burdensome, as many are today, and are really related to results and dimensions that matter for patients. So I expect to see through these kinds of payment reform initiatives more support for improving the availability of meaningful core measures, and I think that's the pathway that the report lays out. We're certainly not there yet, but the Healthcare Payment Learning and Action Network has laid out some common frameworks and approaches for implementing these alternative payment models and some recommendations for how core quality measures can be used in support of them. The Physician-Focused Payment Model Technical Advisory Committee, or PTAC, is, I think, likely to look at models for alternative payments in specialized areas of care, including many types of oncology. So I'm considering, I think, some prostate cancer related care measures soon, again with a focus more on the person and the whole episode of their care rather than the individual services. So that should create more resources for improving measures over time. I think these will be gradual processes where we don't move all of a sudden away from fee-for-service to alternative payment models, but again, can provide that kind of alignment and reinforcing that Alan was describing. To help with these efforts, measure prioritization and measure development also matter. There are a number of national initiatives underway that are working, I think, increasingly collaboratively to make available validated, reliable measures and methods for calculating them that can be used for quality improvement and payment and other activities. The National Quality Forms Measure Application Partnership is one example of this, making recommendations to CMS about measures for its quality payment programs and MIPS. The Core Quality Measure Collaborative has measures that have been adopted in some of the alternative payment models that I described, while not yet focusing as much as I think many of us would like on patient-reported outcome measures. It does provide a pathway across payers and oncologists and other stakeholders to get to some consistent measures in use. So a lot of opportunities to build on progress there. And then more support for measure development. Tom mentioned the NQF incubator earlier, and the International Consortium for Health Outcome Measurement is also working on measures in some areas of cancer care, and I think we'll see some disruptive actions here too from some of the patient groups, like Alan was mentioning, that are starting to collect on their own through social networks and direct engagement of patients, some more consistent and reliable measures. So all of that can be reinforcing. I do want to end by emphasizing that it's not just about payment. Bob mentioned CancerLinQ, which is bringing together electronic data and other data sources to help learn about what works and how to do it more and help oncology practices do those things more reliably. All of these can reinforce each other to help make more rapid progress. So really leading council cost, a lot of opportunities for improvements in care and further innovation to get better outcomes and avoid unnecessary costs, but also a lot of measurement challenges along the way. And all of these dimensions are trying to support better outcomes, better evidence, quality improvement, payment that aligns with what matters most for getting better outcomes for patients. So it's a journey, and I think this report is going to be a very important source of a roadmap for how we can make that journey more effectively and use measurement for what it should be doing, supporting better outcomes and lower costs for people. Thanks very much, and great to be part of this effort. And I think we are now turning back to Tom for questions and further comments.
Thank you, Mark, and thank also to Alan and Bob. So as the questions from the audience are queuing up, I have a few that I'd like to toss out to our panelists. Starting with you, Mark, in my line of business, I get a lot of questions about what are the implications of a new administration on accountable care. Are things going to proceed as we've been working toward accountable care for the last several years, or are there going to be big changes? I know that you have insight into this through your leadership role on the land and other work that you're doing with the department and with CMS. So if you wouldn't mind commenting on that, we'd certainly appreciate it.
Sure, and I think just as we've been talking about the challenges in delivering better care and how payment reform is one important support for improving care, that is going to continue. That hasn't been a part of an issue, for all the debate about repealing and replacing the ACA, programs like the MACRA payment reforms we've been discussing, and programs like the Center for Medicare and Medicaid Innovation. They haven't been part of that partisanship. I think that's because there is just a broad recognition that we need to do more to pay for results that matter to patients, that our current systems, including in cancer care, often don't support the care coordination, the extended office hours, the care planning, and other steps that really are important to get better outcomes. So that said, I do think the administration may take an emphasis in payment reform in new directions. Dr. Price has highlighted some of his interest in the so-called physician-focused payment models, which I think you can read to be about models that focus in on more specialized areas of care. Recently, PTAC reviewed and favorably reported, for example, on a payment model focusing on patients with serious gastrointestinal diseases, inflammatory bowel disease patients, and I mentioned earlier that there might be areas involving prostate cancer and urology that where there's interest in moving in the same direction as with the oncology care model and care that's coordinated primarily by oncologists. But I don't see a fundamental change in that in this overall direction of trying to align payments, align them across multiple payers more effectively with results for patients. Maybe, again, more of an emphasis on physician-focused models, more of an emphasis on state and state-based multi-payer approaches, or approaches through private plans as well as traditional Medicare. But I think the push is going to continue in that same direction. It certainly seems to be what many private sector leaders are saying now as well, both on the provider side and the payer side. And this is a quick plug. If you want to learn more about where things stand and where they're going, Tom, you mentioned the Healthcare Payment Learning and Action Network. We actually have our virtual summit for the spring on Monday, and information is available on the web at the Healthcare Payment Learning and Action Network website on the virtual summit, and that'll be a chance to hear about some of the latest developments in the public and private sectors, on CMS and HHS perspectives on where things are going from here. But it is all moving forward, though it is a challenging process, as we've discussed on this call.
Thank you, Mark. Very helpful insights to share with the group, and certainly underlines the final point from your presentation about the importance of this work, the ongoing importance. Alan, if you're still with us, I'd like to ask you a question related to patient input into their care, specifically about patient preferences.
Sure.
For so long, we've been focused on the clinician's role in care, the clinician's role in quality of care, and clinicians are, in their professional estimation, very focused on the outcomes of care. But now we're thinking more and more about patient-centeredness and the role of the patient. So how do you think about this balance between our traditional view of focus on professional driven clinical outcomes versus the patient input into care, and specifically patient preferences for care?
Yeah, I mean, I think it is. Thanks for the question. I mean, I alluded a little bit to it in my comments earlier, but I think it is it's, as you put it, a balance. And I think it just philosophically speaking, from a patient perspective, if patients are increasingly being asked to pay more out of pocket for their care, so whether that's through specialty tiering, whether that's through high deductible health plans, whether that's through health savings account, and I'm not suggesting that's necessarily a bad thing, but it changes the dynamics. So it's not just patients are no longer just paying a small portion of just paying their premium or paying a small copay. Increasingly, we're paying more and more of the cost of the care. Insurance still plays a very big role in protecting us from the total cost, but increasingly patients are exposed more and more to their own in the out-of-pocket sense. So I think that raises sort of I dare say, an obligation to really let the patient's voice be more incorporated into the decision-making process, as they are paying for more and more of the cost of it themselves. But that aside, I think just from a quality care perspective, I think if you're truly trying to deliver quality and value, that really there's a level at which you can evaluate that and think about it at the population level. But at the end of the day, and if you're talking about sort of the provider-patient relationship, the delivery of that quality and what matters is really about what matters to that patient. And can you create a care experience and a treatment plan and a care plan that really meets that patient's needs? And you can't, and that's really how you're going to deliver quality at the individual level. And obviously, if you do that repeatedly, then aggregate that together, and you've created quality at the population level for your patients. And most providers want to do this. They're dedicated to it. They just, for a variety of reasons, there's lots of things getting in the way of that. But I think that the need is, you can't get there without starting with that fundamental question of a patient about what matters to them. Now, the provider obviously brings a lot of the expertise around the evidence and what are the options available to patients that are within guideline and when there might be appropriate off-guideline care. But then, what the patient is really an expert in are the things that matters to them and what's important to them and what are their goals in life and what are their goals for care and treatment. And really, those two things have to be married together to really deliver quality. And if it's simply, the system's going to tell you what to do, or the pathway is going to tell you automatically what to do, or the provider is someone's going to decide for you before they know anything about you what is appropriate care or valuable care. I think it loses the personal. It loses the personal touch. B, it ignores the fact that the patients are paying out of their own pocket for some of it. But C, it really loses the opportunity to deliver high-quality care, because at the end of the day, it's really that personal relationship and the dynamic between the patient and the caregiver about what's important to them and how to develop a treatment plan that really meets those two needs of what does the evidence support versus what is the patient's goals and preferences. If you can figure out how to do that and incentivize it, I think you've gone a long way to creating a system that isn't just a healthcare system that actually delivers health and delivers care. And that's how you make sure we don't lose the humanity of the whole care system. If we lose touch with that element of really trying to deliver care in a way that matters to the patient and include the patient in that decision-making process in a way that's meaningful to them, then I think you've lost some of what really matters to patients is that level of personalization and respect and the fact that they're listened to, and that what matters to them is incorporated into what we do to patients, and it's just as important as trying to figure out what's the matter with them.
Thanks, Alan. Really appreciate your emphasis on the idea of a goal concordant care plan and the patient's role in that, because I think it helps to resolve this issue about what do we want to measure, and how do we make sure that we're both patient-centered and at the same time somewhat standardized in our measurement for assessment and improvement. So it helps to find the balance. I have a question for Bob Miller. And Bob, it has to do with your evolving role at ASCO, which is focused more on data. And I think one of the conclusions of the roundtable, and certainly our last recommendation, was about the importance of continuing to build and improve the data platform so that we can continue to improve measurement. Could you talk a little bit about the things that you're focusing on in terms of the oncology data platform and about the reactions of your ASCO members to having better data, to getting to better data, to getting over the enormous burden that they shoulder in terms of data collection?
Yeah, sure. I'd be happy to. Thanks for the question, Tom. So as I mentioned, we've been working on the platform that we call CancerLinQ, which stands for the Cancer Learning Intelligence Network for Quality. It's a big data health technology platform, but it's really an extension of ASCO's earlier quality-related portfolio, the COPI program and extension of the clinical practice guidelines that I was speaking to. But I think the main difference with CancerLinQ compared to some of our older programs is that it's fully electronic and fully automated. Even though we've had within our membership, we've had a robust response over the last 10 years to the manual COPI program where doctors, had to go into the charts manually and pull out the results of the clinical quality measures. In the modern era, you really can't you can't overestimate the amount of the burden that this is, both the time spent doing the data abstraction, pulling the records and so forth. I remember when I was in private practice back in the paper chart era, we did it all manually. It was my nurse practitioner and I locked ourselves in our chart room one weekend and went through a few hundred charts just to pull out the quality measures. So what ASCO is trying to do with CancerLinQ is to establish a direct data feed with the electronic health record, pull in the data elements that we know are somewhere in the record, and use those to fire clinical quality measures. But that's easy to say in a few sentences. It's very hard to do practically, and probably the biggest reason relates to data availability and some of the issues that we talked about at the roundtable and in the white paper that many of the important oncology-related data elements simply are missing within the native systems. So I think one of the recommendations that it seems like these type of reports always say, but you just can't underemphasize it, is the importance of interoperability and the importance of standardizing the way some of these basic data elements that describe the patient, the cancer, the care, the endpoints that are critical to patients. These things have to be captured better. They have to be captured more systematically, and that's some of the work that ASCO's taken on with the CancerLinQ program. It's an enormous challenge. We've had a tremendous response from our membership. We have about 1 in 6 oncologists in the U.S. that are part of CancerLinQ now, but it's still early days for us. And I'll say that it's not fully automated and ready to do all the external reporting requirements. We're still getting the data right, but can't speak loudly enough about the importance of doing this in the modern era in this this automatic, electronic, and digital fashion. We have to get all members of the ecosystem aligned with this: the EHR vendors, the payers, certainly the practitioners, the policymakers. Everyone has to prioritize this because this type of automated system will give us the best picture of really what's going out there and the best opportunities to improve the care, I think.
Thank you, Bob, and also Alan and Mark. Great discussion today. And Kimberly Westrich is going to close out the webinar.
Thank you all for joining us today. We have gotten some questions about whether or not the slides will be made available. Yes, we will be making the slides available, and the recording of the webinar should also be available in about a week. And that concludes today's webinar.